Buenos días, muy bienvenidos, muy bienvenidas a esta reunión, a este seminario.
Good morning. Welcome to this seminar organized by the World Association of Sexual Reproduction and the CLAP, the Latin American Perinatology Center, Women's and Reproductive Health, as a specialized office of PAHO. We wish to welcome you warmly. And before starting, I have some announcements. In the bottom part of your screen at right, you're going to find a globe. And that is the icon for interpretation. You can choose the language with which you're going to listen to the translation that is being translated into English. We're going to have a very carefully designed seminar on behalf of the Latin American Perinatology Center and on behalf of Dr. Ciruja, the director, who has apologized for not being able to attend early on due to a personal inconvenience. We wish to tell you that the contact of PAHO together with WAS as two organizations that are part of the health concept is extremely important and has long years. Today, our meeting will refer to the analysis of new concepts in health and sexual health in particular. In the midst of a crisis that is unprecedented, as is the pandemic due to COVID-19 that has had huge impact on all our lives of all individuals and on the health and health systems and access to health systems for our population. That's why we'll relate the concept of sexual health initially, that is clearly defined as a state of physical, mental, emotional, and sexual well-being, not only absence of diseases. Sexual health has a respectful way of looking at sex and the possibility of having safe sexual experiences free of coercion and violence. To have and maintain sexual health, sexual rights of all persons must be respected, protected, and complied with. Today, we'll have with us a wonderful panel. And the idea, the goal, was first to introduce new visions we have regarding issues related to rights, justice, and sexual health. Second goal, to have a conversation about the impact that the COVID-19 pandemic has had on sexual health in some countries in Latin America, and we'll share some findings in research that are quite powerful and have been developed in the region. And last, include some common strategies to protect and increase the sexual health we're referring to as part of a comprehensive health and within the development of peoples. Without further ado, I'd like to now hand the floor and welcome once again all. We have over 120 people with us in this forum. And Esther, if you want to introduce our new wonderful panelists, please do so. The floor is yours. Good morning, first of all, to all our audience. It is a privilege for me right now to introduce Dr. Pedro Nobre, who has a PhD in psychology, professor at Porto University, who has founded one of the specific chairs for sexual health, in my view, the most important in the world. But I would like to introduce him more particularly as a former past president of WAS, the World Association for Sexual Health, was, according to the acronym in English, where we worked together 4 years, well, and even before, and now still, he as part of the executive offices, and everything Pedro has done during these 4 years has been a task of gathering many of the different threads, some that were loose and some already knitted, and this in the midst of the pandemic. So, Pedro, thank you for being here. Your CV will be on screen. We don't have time to read it, because if we were to do so for all our participants, we wouldn't have any time left for the discussion. Thank you, Esther. I don't know if you can hear me well. I believe you do. To start, I want to thank Esther and Rodolfo for organizing this important event. I'm going to speak in a mix of Spanish and Portuguese, Portuñol. I'm from Portugal. I apologize for my poor Spanish. I'll do my best. It's a pleasure for me to be here once again. And as Esther said, together we have worked long years in the World Association of Sexual Reproduction, and we have this strategic association as a world association, and together with CAHO. So I'm very grateful to everybody, and particularly Rodolfo, for this occasion. I'm going to share my screen with you. Let's see if I manage to do so. I think you can see my screen now. Yes, perfectly well. So the goal of my conversation today is to refer to new scenarios in sexual health, sexual rights, and sexual justice from the standpoint of the World Association for Sexual Health. Briefly then, for those who are not familiar with WAS, it's a multidisciplinary organization founded in 1978. We have practically 45 years, and we're the greatest in world association, representing many organizations and thousands of professionals in a variety of disciplines throughout the world. And the mission of WAS is to promote sexual health throughout human life in the whole world by development, promotion, and support of sexual health and sexual rights for all. As you can see, a very ambitious mission. Rodolfo, a few minutes ago, said that it's very important to count with a starting point, this idea that sexual health is much more than the absence of disease. And this means a positive approach to sexuality that is respectful, and the possibility of having pleasurable sexual experiences that are safe, free of coercion, discrimination, and violence. And that is an extremely important definition for us that is elaborated by WHO, and WAS has played a significant role there. Now, I will briefly conceptualize the importance of everything WAS has done in collaboration with other organizations for the health rights, and let's say more recently, this idea of the importance of sexual justice that is closely connected to health and sexual rights. Now, a bit of the history of WAS. We can start saying that an important framework has occurred in 1999 with the Declaration of Sexual Rights. And this declaration has been adopted first by the World Congress in Valencia and acclaimed in Hong Kong in the World Congress in 2020. And this is important because it is for the first time that WAS was devoted mainly to the importance of sexual rights and their relationship with sexual health. WAS has also been related with a significant development of sexual health for the millennium. This is a very important document issued in 2008 that was done together with the Pan-American Health Organization with the principles for sexual health for the new millennium. And we've also participated in important documents and developments, particularly in defense of the rights of trans people, here together with Pan-American Health Organization 2012. And in 2014, there was an important highlight, and that's a new declaration of sexual rights. In this new declaration, the most important part has been the conformity of sexual rights with, or as human rights. So each sexual right in this declaration are essentially linked with each of the human rights. That is why this idea that sexual rights are in and of themselves are a human rights for all. We have also produced documents in collaboration here with IPTF on sexual rights of youth, an important document on how and which are the basis for the main aspects related to sexual rights of young people. And another more recent framework that is very important, that's the depathologization of gender diversity that has occurred together with a new ICD 11 of WHO adopted in 2018 with a first chapter for conditions related with sexual health. And this has been a significant framework for many, meaning and symbolizing depathologization of many circumstances, and in particular matters related with gender diversity. More recently, at a conference hosted in Mexico City 2019, we had a new development, and that was the Declaration on Sexual Pleasure. And once again, sexual pleasure is a central aspect of sexual health. As you've seen, the definition of sexual health includes this possibility of speaking of pleasure and pleasurable sexual experiences.
And that is why pleasure is also essential, and it's a human and a sexual right. Another very important framework that many people have worked for is creating the World Sexual Health Day. And this has been celebrated since 2010 on the 4th of September. All the global and national organizations collaborate with us to raise awareness and to call people's attention to the importance of sexual health and the sexual rights for all. And this is a very important day. It's a symbolic day because it's more important to consider what happens the entire year, not just one day, but it's a symbol. And from the strategic point of view, we are trying to have partnerships so that these days may be formally seen as the World Day or the National Day of Sexual Health, and a global day or a World Day recognized by the WHO, and considering it as a whole. And in July this year, there was a significant event too, that is that Portugal became the first country in the world to formally recognize the World Day of Sexual Health. And I'm very proud of that because I'm Portuguese. But I think that it could be considered an example for all the countries and all the other partners, so that the importance of sexual health may be formally recognized, and this raises more awareness, it causes more debates, and certainly it will help us promote health and the sexual rights of all. Finally, I wanted to share with you that very recently we had a World Congress of Sexual Health that was virtual. Unfortunately, we couldn't be present in El Cabo, in Cape Town, in South Africa. But we know that it was a lot of people participated, and we are developing two large lines. One is about gender diversity and transgender and the importance of the rights of people with gender diversity, and an initiative that has to do with sexual justice. This is not a new idea, but it's an idea that has not been well developed, and we believe that it plays a key role. Sexual justice is clearly linked to social justice and justice overall, but it's a specific point of social justice, and it is very connected with the rights and sexual rights and sexual health. So hopefully, together with PAHO and WHO and other organizations, we want to work so that this concept of sexual health may come closer to our mission. Finally, some challenges for the future. I believe that in this area, it is very important to work in collaboration, global cooperation, international cooperation, the big organizations, but also the local organizations, because it's only through such cooperation that we can reach far enough. And we face a world that is always changing. We can almost consider that we have a post-COVID world, and we have many new opportunities. We have a digital world, and everything is possible. Now we are speaking from different places in the world, and it's very easy to communicate through a computer or a telephone. And this brings opportunities that we need to explore the best way possible. Another important area, increasingly important, is to have an intersectional vision. The differences, the inequalities that across the different areas, sex, gender, race, social status, etc. And so the idea is not to leave anybody behind. And so the diversity needs to be represented at all levels. And all of this, as a matter of fact, requires more social justice. And another area that is important is the importance of knowledge, the importance of scientific evidence on the key topics of sexual rights and health. And here, let me mention two important things. WHO is a global sexual health survey that's going to be very important for the future, because we'll be able to use a global measurement that will be possible to implement in throughout the world, and we're going to be able to compare and to understand the situation of all the systems. An example of how this is possible in a short period of time is the example of iShare that we'll discuss here with different degrees in different countries in Latin America on sexual health in COVID times. And finally, a project that is related with all this, project is the creation of a World Observatory on Health and Human Rights. sexual rights, and the idea is to contribute to the extent so that we'll be able to increase our evidence-based scientific knowledge that is supported and that is used in different countries and that we can compare and continue. And so this is a core idea, because if we want to change, if we want to promote health, the rights, we need to be evidence-based, showing the importance of all of this, sexual health and rights, and the state of the art all over the world. And finally, from the point of view of WAS, as past president, it's a pleasure for me to invite you to become members, because together we'll be stronger. So that's why we wanted to welcome all of those who want to join us, and thank you for your attention. Thank you. Thank you, Pedro. It was a pleasure. Thank you, Dr. Pedro Noble, for sharing these concepts with us. These are key concepts. They are clear, very clearly expressed, compelling, and strong. And now we're going to hear the next speaker, my colleague, Natalia Hilton. Let's see the next topic. And we thought that this would be very relevant for our seminar. So there are no pandemics in recent years with such an impact. It's changed the life of almost everybody, and it has caused changes in the access to the healthcare systems that have made significant changes, huge changes, especially in those that already had difficult access in the most vulnerable populations, and it has caused deaths and lockdowns as a response by the healthcare systems, and this has brought about other issues. I'm very proud to introduce my colleague Natalia Hilton, that is an expert on data management, and she has a master's degree on Georgetown University. And as you see, her resume has been shared, and she's part of a team that in PAHO analyzes the impact of these pandemics at the level of populations and healthcare systems, and they are with us in a continuous analysis and monitoring that PAHO has been performing, and especially she will share with us why this COVID-19 pandemic had an impact, and then we'll see when we can start speaking of a post-pandemic, but we are in the midst of the analysis. Natalia, thank you for being with us. Here we let you share the information. Thank you, Rodolfo, for inviting me to participate in this event in such an important topic as sexual health. Good morning, everyone. Let me share the screen. Could you please tell me if you see it? Yes, perfect. So, as Rodolfo said, I have the pleasure of giving you an overview of the impact of the pandemic in the Americas, with a focus on the health systems and the conditions of access to, especially with the vulnerable populations, and specifically with respect to sexual health. So let's start with the impact of the pandemic in the region of the Americas. Our region, unfortunately, has been the worst hit by COVID-19. Even when you look at the data of confirmed cases and mortality due to COVID-19 in the world, you see that the Americas was the epicenter of the pandemic. About 38% of the cases confirmed were in our region, and 46% of the deaths in the world have been reported in the Americas, although we are only 8.4% of the total population. So really, it's been terribly affected by this public health crisis that we have faced for more than 1.5 years. Of course, there have been cycles. It's varied in time, and in the last epidemiologic weeks, the cases of COVID-19 have dropped if we compare them to August to the present. However, it's important to remember that we've also have different waves of the pandemic. So right now, it's difficult even to see when we are going to overcome such an unusual crisis that we are all going through. So as a matter of fact, when you introduce the different strains of COVID-19, you may see that there were different waves in different countries in the region, even with a number of COVID-19 that were much higher in the second waves as compared to the first wave of COVID-19 last year. That is the case, for instance, in Argentina, Brazil, Colombia, Peru. Those were countries that were very hardly hit by the pandemic, and the mortality rates were even higher this year after the introduction of the different variants of COVID-19. So this poses a difficult challenge to control this public health crisis. The other important thing to consider is that the pandemic indeed has had a disproportionate impact on the populations with a higher vulnerability. The ethnic minorities and the lowest income populations have been hit tremendously, and the severe cases of COVID-19 hit them disproportionately, and the negative impact on the living conditions of these populations in this graphic. So this, when you see the excess of deaths in the 2020-2021 prior to the pandemic, you see that the most vulnerable countries, in this case, consider the SDGs,
countries with a lower vulnerability index, Peru and so on, have had excess vulnerability greater than others with sustainable development figures that are better, such as Canada, Cuba, Chile. So we see the disproportionate impact of the pandemic in countries with worse life conditions for their populations. I recall the significant impact of the pandemic in increasing social inequalities and also health. If you think then of the reasons why the Americas has been so impacted by the pandemic, we see this issue of structural inequalities, vulnerability, and social exclusion that are historical for the Americas, and therefore are and were a challenge before for policies and interventions considered to respond to the COVID-19 pandemic. And in turn, we have all the historical weaknesses of health systems in the Americas that unfortunately have been underfunded, with segmentation in funding and also significant fragmentation in provision of services that also has deepened inequalities regarding access of the population to the necessary health services. In turn, we have very weak social protection services, even in the health area, that somehow show differences regarding the guarantee for the right to health. according to social and economic conditions of the population groups in the region. The outcome is a very significant proportion of the population in our region that has seen its basic needs unsatisfied during the COVID-19 pandemic, without forgetting that before the pandemic, we were already facing a very disencouraging situation. For example, 30% of the population in the Americas had their needs for health care unsatisfied before the pandemic. So if they had a disease or an accident, couldn't manage to access the necessary health services due to different access barriers, geographic, because the health services are scattered, issues of acceptance that are so important and are highly related to social standards and gender roles and availability that the population has to seek for services, even in the case of sexual and reproductive issues. It's important to recall that prior to the pandemic, close to 26% of women didn't have the necessary empowerment to reach a decision regarding their sexual and reproductive right, including the decision regarding their health and the use of contraceptives and decision-making in the home. And this impacts negatively on the way they seek for health services. Of course, we have financial barriers, administrative barriers regarding the organization of services. Before I mentioned issues regarding fragmentation in the supply that all impact in a disproportionate way on the worst of the population, as expressed in these graphs. What does a pandemic bring? Well, a worse situation. This is the outcome of the continuity survey on essential health services during the COVID-19 pandemic. First level of care services have been more highly hurt by the pandemic. Close to 55% of countries in March, April reported an interruption in the provision of first level of care services. And this is a cause of alarm, because we should recall that the first level of care is where most of the vulnerable population access services. Maybe it's even the only contact for these population groups. And it's also the epicenter for the control of pandemic, even vaccination services and the pillar for primary health care, historically underfunded, of course. So this was a great cause of alarm when identifying this high level of interruption in these services. If we look at priority health areas, we realize that the interruption of services is cross-sectional to all priority areas of health, in the particular health of reproductive health, maternal, neonatal, infantile, adolescent. 41% of the countries in the Americas region reported between March and April discontinuations in the provision of these services. Indeed, if we compare the rounds of surveys, the situation in 2020 as compared to 2021, in March and April, we realized that the percentage of countries reporting interruptions in the provision of reproductive health, maternal, neonatal, infantile, and adolescent increased from 36 to 43%, and that is a sad reminder of the impact of the pandemic in the provision and conditions to access services, and warns regarding the need to implement mitigation strategies in order to guarantee continuity of access to all health services, and particularly these types: reproductive, maternal, neonatal, infantile, and adolescent for the population. If you look inside these services to see which have had the greatest percentage of interruption, we see that reproductive health, such as planning, family planning, contraception, and also prevention and response to sexual violence, have the highest percentage. 52% of countries reported an interruption in the provision of family plan and contraception services, and 50% reported an interruption in the provision of services to prevent and respond sexual violence and within the couple in the Americas in April. The reasons for these discontinuations are many, but perhaps we ought to highlight, on the one hand, those related with the responses provided by governments to respond to the COVID-19 pandemic, and that have meant a displacement of all resources, mainly human resources, to respond to the pandemic and COVID-19 cases, leaving aside essential health services. We realize that even in the 2 rounds of this survey, 65% of countries reported the reason for discontinuation of access to the services, the deployment of health personnel to respond to the COVID-19 epidemic, impacting on the provision of other essential health services. But in turn, we have issues related to the demand of the population. The population is also affected by restrictions in motility and the fear they may have of accessing services, so don't attend consultations, particularly those related with promotion and prevention of health services. So this is a double challenge then for health services, to guarantee on the one hand the supply of services related with COVID-19 in particular, but also guaranteeing continuity of access to other essential health services that are a priority and necessary for the population. Now, looking at the possible consequences of the interruption in access to sexual and reproductive health services, there is some evidence, very little still, unfortunately, but we have some studies that speak that as a consequence of these interruptions, increased non-planned pregnancies in adolescents and young women, higher rates of HIV cases and STDs in Latin America. 18 million women will lose regular access to modern contraceptives. There's been an increase in the probability of neonatal and maternal deaths in the last study, close to 1.28 and 1.37 times more neonatal and maternal deaths during the epidemic as compared to the period before, and increase of postpartum depression as a consequence of the worsening of the mental health situation of population as a consequence of the pandemic. Also, a great increase of domestic violence against women and girls that has increased up to 30% in some countries. A very difficult situation for the health services and the population in the Americas. We may conclude that the magnitude and extension of interruptions in provision of essential services persist in most cases. When we see these surveys from the beginning of the pandemic 2020 versus 2021, they persist and have even increased in some services, particularly for reproductive health, maternal, neonatal, infantile, and adolescent health, where there's been increase. It's necessary, therefore, to guarantee that COVID-19 control strategies be balanced with priorities in health to guarantee continuity and access to other essential services that are not related to COVID-19. It's essential to have fiscal policies when allocating resources in order to control both the pandemic but also mitigate this impact we've observed in the provision of essential health services. A lesson learned is not to allocate all resources exclusively to respond to the pandemic. We must also guarantee resources to guarantee continuity in provision and access to essential health services related to COVID-19. We must organize provision of services within the comprehensive health program, but also the first level of care that has been suffering more, and resolve the health needs of the population. The pandemic reminds us of all the principles of AMATA and the recent declaration regarding the need to prioritize the first level of care, both at political level and in investment, to ensure continuity of access. And last, and strengthening the item mentioned by Pedro, the need to reach decisions based on evidence. It's important to know the impact of the pandemic in the provision of all services, particularly sexual health, in different realities, local and contexts, to consider the planning to respond to the pandemic in the continuity of these services, and evidence regarding the effectiveness of mitigation strategies implemented in the countries to guide a more effective response and thus guarantee access to the population. Thank you so much for allowing me to speak to you. Thank you. Thank you, Natalia, for this brilliant, short and very concise presentation that gives us an overview of what is involved in this pandemic in our region of Latin America and the Caribbean, but also for the world, although we will focus on Latin America and the Caribbean. The reason why we are translating this seminar into English is because we really want to include our colleagues from the English-speaking Caribbean. This is why we have the translation in English. This is being recorded and will be freely available when this ends. Thank you, Dan. Let's now hand the floor, after having made clear the concept we wish to work with, particularly regarding sexual health and access to health services. Providing and guaranteeing sexual health will now work, having understood the impact of the pandemic, in a special research that a consortium, a global consortium of researchers and academics, headed by the Health and Hygiene School in London, and this consortium with a very large group of organizations that have participated to think about this new modality regarding the impact of the pandemic in sexual and reproductive health, considering virtuality and telecontact. What we're doing in this seminar, as Pedro said, with colleagues from all the world, Europe, America, and the rest of the world in a single place.
This consortium I share, that is an international survey on sexual and reproductive health that specifically researches the impact of this pandemic on people's life in this area. So let me show you. In this slide, I'm showing you what the website is all about, how you can enter. It's an open website, and we have the possibility of understanding. I'm going to very briefly tell you what it consists of and what was the technical modality of the survey that was virtual. 34 countries participated with 34 different representatives that appear here in the map. Here you have the people who participated, and the modality, as we have here to the right, it was a transversal survey. It was a free of charge survey, and it was random. The most important requirement was being older than 18 and to have an informed consent, to sign an informed consent saying that you were freely participating in the answers. The size of the sample for each country was more or less a minimum of 200 people. considering gender, age, and income level to make sure that it was a representative sample of the country. The surveys were disseminated locally in each of these countries, and they used the networks for dissemination of information as Twitter, Facebook, and Instagram. And basically, as I said, there was a virtual access to the agendas. The countries initially were 33, then they added a new one, 34. And here you have an example of how each country had the possibility of adapting, adjusting, and defining the questions, adapting them to the language in the country, not just to language, but also to how this would be interpreted. So having a common information and then sharing that information with the rest. It was published in the Lancet. It was, they published a quick comment very clearly defining the 3 moments for research. First, the design of the study with the online panels and the recruitment of the researchers. So, and they're very prestigious researchers that participated of the 34 countries that were responsible for the implementation, that are representing the local institution. And they adjusted the survey, and it was done in a very innovative way with multi-level analysis. And I hope that you enjoy what we are going to share now. And in the right panel, there was you see that there was a publication where the protocol was clearly defined, and you can see all the details of the methodologies that were used and how they adapted them and who are the main responsible for these 2 institutions. And here you can see a publication just as an example of the study in Panama. We have the great pleasure of having today among the panelists the first author of the study, Amanda, who is going to share with us some of these results. Amanda Gabster. So this is the methodology. Now let's give a very warm welcome to the panelists of our table. We're going to have the pleasure and the honor to have the principal investigators in some of these countries. First, well, I was not introduced, but I'll do that myself. I'm Rodolfo Gomez Ponce de Leon. I'm the regional advisor on sexual and reproductive health of the Pan American Health Organization with a headquarters in CLAP in Uruguay. I'm a gynecologist and I have a doctor's degree in obstetrics and a master's degree in mother and child health. My co-presenter, Esther Corona, is a clinical psychologist. She has worked all her life on sexology and sexual health, and she has multiple publications. She's a Mexican, and she was a vice president, just as Pedro Nobre of the WAS. So she has a marvelous experience. She's worked a lot on sexual education in her country and in the world. So it's a pleasure, Esther, to be with you, to be sharing the chair. The first presentation today is by Gabriella Perrotta from Argentina. She has a PhD in psychology at Buenos Aires University, and she's technical coordinator of the Ministry of Health in Sexual and Reproductive Health in Argentina. In addition, she has multiple publications and many papers. Our second speaker will be Amanda Gabster. She's an American. She lives in Panama. Amanda has a PhD in, she's a biologist from Canada University, and she has a PhD on tropical infectious diseases, obviously in one of the prestigious schools of in the London Tropical Diseases School. And then we're going to have the principal investigator in Mexico, Eusebio Rubio, who's a doctor of the University La Salle of Mexico City, who completed his doctorate program in human sexuality in New York University. And today he is professor of the Department of Psychiatry and Sexual Therapy in Mount Sinai in New York, and he's professor in Mexico, and he has also many publications on the topic in more than 25 years of career, and he's going to tell us the data that he found in Mexico. And finally, the last case will be sociologist, magister, and doctor in social sciences, Nicolas Brunet from Uruguay, who will tell us what he found in Uruguay at the School of Psychology at the University of the Republic in the Department on Gender, Sexuality, and Reproductive Health at the School of Psychology. So I'll let you with the first speaker, our colleague Gabriella Perrotta, who will share the findings of the study in Argentina. Gabriella, you have the floor. Hello, good morning, good afternoon. If you're around, let me share the screen. It won't let me. Let me try again to see what's happening. It's not easy, but we're going to solve this. Can you see it there? Yes. That's very clear. Okay, so I thank the three previous presentations because they are an excellent introduction for this survey. First of all, Natalia is telling us our worries as to the impact of the pandemic and the isolation measures, especially considering access to sexual and reproductive health. And I want to highlight the difference between the two, because sometimes we put them in the same bag, sexual and reproductive health, but at least I want to state it now so that we can discuss it later. The difficulties in access to services and the consequences in the health of these difficulties. This is what led us to have this survey, to see more concrete what was happening, First, Pedro, to highlight the rights. In this case, sexual rights and the right to gender identity. And Rodolfo, with this introduction, thanks to what he said, I can go quickly through these slides and go directly to describe how we tried to build this survey as a global survey. So it was not easy because over 30 countries with different realities. The one thing they had in common was that they were all with a pandemic, but with different access to health and different legal frameworks. So we had discussions with the consortium and with the leaders of the different countries, and we even put together a Spanish-speaking working group where we also had very interesting exchanges, and we could introduce some changes. So we changed the initial proposal of the consortium, for instance, asking about gender and not the person's sex. So responders would only say the gender and not the sex. The sample in Argentina was 845 people. Rodolfo said that an attempt was made to have the sample representative, but actually in most countries it was not statistically representative because we had no resources to build a design specifically for each country that could be statistically representative. So in Argentina, it wasn't. We disseminated through the social media. And this sample, well, the people especially belong to the middle class, usually with a university level over 90%, and over 80% is an urban population. So it's a very peculiar population. It doesn't represent what we would have liked to have. And this happened in many countries. In our sample, 80% were women, and only one person stated that it was a male trans, a woman trans, and two non-binary, and almost 73% is young adults up to 39 years, and 66% didn't have any children, and more than 85% said that they were heterosexual. Although concerning the access to the care of sexual right and reproductive health, there was a low percentage of reporting of difficulties in this access, in the access to contraception especially. Natalia was telling us that in all the countries there were difficulties in access, and there were difficulties to offer care and supplies, but people were afraid of the cases of leaving home, and they didn't go to the healthcare centers where they could get information. But in spite, or in this report with low rates of difficulties, more than half of the people who reported difficulties were between 18 to 29, the youngest people. And so the young were the ones that had more difficulties in access, and we're worried about another topic that worried us a lot, and Natalia introduced it very well, is that we know that violence situations increased a lot, especially domestic violence, gender and domestic violence during the pandemic, especially during when there was more isolation. But we didn't find significant differences in our results in Argentina with this study between what happens both in the situations of violence, physical or psychological, before and after the adoption of social distancing measures. And we were something that surprised us. We're going to listen to Amanda and Eusebio because they have similar data that we can discuss later. We were struck that in the report of the people that live as a couples that reported violence, there's a greater percentage of men than females that report violence. This is not consistent with what we know about the situations of violence that men or males suffer in our country or in any others. So that warrants an analysis that I'll now proceed to do. And the other thing was to think some things about the effects of the pandemic and mental health.
Mental health, and more specifically within the question, there are two of interest to try to gauge the situation, these two here, if people felt frustrated with things in general, and if this occurred more or less as related to social distancing measures, and if this was related to a small provocation. If we think of women, 32% of males and 52% of women said much more than before in relation to two questions. So on the one hand, this sample obtained is focused on the population group with higher economic and symbolic resources, and therefore greater possibilities to access to healthcare. So the results are not enough to reach specific conclusions for our country. On the other hand, regarding the consequences of the pandemic on mental health, we see this gender difference. Women are those that report more irritability and frustration, and that we must consider the extra workload that women suffered during the pandemic and lockdown, particularly during the first months of the pandemic, because apart from the work they did outside the home and in the home. They had their children, with the school situation within the home and chores and so on. And to this, we have to add constant co-living in the home. So situations of violence that in this study do not appear in these specific results, but move us to think, on the one hand, in relation to this piece of information we found that doesn't seem to agree with the knowledge we have regarding situations of violence undergone by women, and particularly during lockdown. This figure according to which males reported more than women. We have to think about two things. First, wonder how to ask when we want to know if people have undergone violence, because the issue is, what does this person understand when they're going to respond about violence and experiencing violence, particularly when we think on psychological violence. And in this sense, we must admit that having an online survey isn't the best instrument, but of course it was the only one possible during the pandemic. And to this, we must add having to reflect and recognize that violence is quite naturalized and silenced. So some women don't answer online surveys because they don't acknowledge they are undergoing violence, and if so, they won't report it in this sort of survey. And as against this, males are not weighed down by this stereotype of submission. So if they feel they are undergoing violence, will report it. Last, then, and also continuing with what Natalia said, it's important to take evidence-based decisions, and we want to guide public policies to reduce the impact of the pandemic, but of the measures taken to contain it. So these results should help us more particularly to reflect upon situations of violence and guide other research to deepen further in these data. We must wonder how to quantify situations of violence that are always so difficult, and sometimes records are multiple and simultaneous. And in our country, it's very hard to have specific data. So we ought to consider the best way of asking and gauging or measuring the violence undergone, particularly by women, but also by collectives and groups that due to their gender, situation, or sexual orientation also undergo situations of violence. So improve prevention and care, and also training of health professionals to detect these situations early on. Thank you. Thank you, Gabriela. Briefly now, let's pass on the floor to the next speaker. Amanda, please. If you wish to share your screen, maybe we will have time for questions because the chat is quite active. The floor is yours, Amanda. Thank you. From Panama, we will briefly refer the results we have as against Gabriela's analysis of programs and methods in the online survey. I won't focus my presentation on violence, but rather sexual activity with casual sex. Briefly then, because we've already heard about this in the other presentations, what is important is that when we speak of the characteristics of sexual behavior before the COVID measures, 3 months before, and during COVID measures, like I show here, this is the first case on the March 9th there. COVID measures were taken in Panama with a curfew on the 18th March 2020. So we set this date as a start of COVID contention measures until we implemented this survey between August 8 and September 12, when the 24-hour curfew was raised. So in this quarantine and with these COVID measures, we had the situation where we couldn't purchase and take alcohol. So it was important to see differences regarding sexual activity during this period. Regarding the participants, we tried to prepare it in relation to the census and the percentage of individuals in rural and urban areas in the country. So we have this sample that is similar to the one for the census. The difference, or slight difference, regards the sex of participants as compared to the census. 960 participants in the survey in total, out of which 59% female. But when we see gender, we break it down according to gender. As Gabriella said, it was very important. We saw this slight increase, I wouldn't say resistance, but comments. Some people that were in the social networks and the Minister of Sexual or Public Health in the country had some contents about gender and non-binary people. Median age was 28 years, quite young. Ethnicity, mixed. As self-reported, as compared to indigenous, or the census speaks of 12% and not 10%. And sexual orientation, we were surprised and pleased to see that percentage of our sample reported being asexual, pansexual, queer, questioning, or other orientations, and we don't have a very large figure for heterosexual. A bit more about the characteristics. We have this significant figure of people who live with 5 more people or more. Nearly 1/3 of the population lost their job or were unemployed during the contention measures. 30% had the monthly family income of the lowest range of $0 to $499 monthly. And last, a bit more than half of the sample had a loss of family income during the measures. As for sexual activity, we hadn't had a previous survey in Panama about sexting. And because the measures were so strict in the country, we had this idea of analyzing this part, where we had 58% of individuals reporting using virtual sex, and here, women and non-binary people. The first figure was males. As to the change during containment measures in the country, we see this increase of 25% in cis men and a reduction in non-binary people. And the use of condoms and casual sex. Casual sex prior to the COVID measures, we see that 32% of our sample of cis males reported having had a casual sex monthly more. And because the measures were so strict, very few people stated an increase in casual sex. However, we had a reduction in some groups, such as cis men, and in non-binary people and women, it's a bit less. And the use of condom with a casual partner. This is before COVID measures. We see that under 40% of cis males stated they used a condom with a casual partner. But if we look here, there was an increase of casual sex here, and in cis males likewise. Now, an analysis of risk factors related with this report of decreased sex with sexual partners, cis males compared to cis women, individuals of African descent. We saw weak evidence of a reduction of casual sex among people that self-reported themselves as gay or lesbian as compared to heterosexuals, increase in sexual satisfaction related with a reduction of casual sex, and we find this is important. Increased virtual sex and a reduction of virtual sex compared with no change in the use of virtual sex. In Panama, then we could hypothesize that virtual sex is used before a meeting face-to-face and also to replace a face-to-face meeting. And we had, in spite of the ban, the people maintained their alcohol consumption or even increased it. And there was a lower odds for reporting reduction in casual sex in those who decreased alcohol and with those who lived longer years with a partner had a lower rate of casual sex. So we have factors related with the use of virtual sex. It increased in cis men, in bisexual and gay and lesbian. It increased as compared to heterosexuals, and increase in porn was also associated with increased virtual sex. And with a long-term partner, participants with a conflictive relationship showed increased virtual sex. As to HIV and STD services, nearly half participants reported that it was harder to get hold of condoms. There was a reduction of the number of times people could go to the supermarket to purchase them, and because the health centers in the rural areas are where condoms are handed, and there was a COVIDization of these health services, things were a bit more difficult. As to 10% of participants in the sample who needed an HIV test or STD, more than half reported they couldn't obtain it due to the COVID measures, and we had 1.6% living with HIV. That is a bit higher, but of these people living with HIV, over half had consultation postponed due to COVID measures, and all these people concerned about the lack of antiretroviral treatment, and national data showed a reduction up to October 2020 of 71% in people diagnosed with HIV in the country. So regarding program and research implications, we want to ensure that we need to prepare our team to guarantee research of behavior during the medical and pandemic crisis in Panama, guarantee care and HIV detection during sanitary crisis. And last, we had this possible window of reduction of sexual casual contagion as compared to the increased use of HIV tests in particular.
That could have interrupted the transmission chain. Thank you, Amanda. We have very little time. We are very grateful to all the speakers that respected the time. And now we introduce Eusebio. Please, Eusebio. Let's see whether we can have some time for questions. Yes, if I may, I want to share my screen. I'll be brief. Something happened. I'm going to change my strategy. I'm going to share this. I'm sorry, I'm wasting time. Please, I beg you to bear with me. Be patient. You were sharing the presentation very well just a few minutes ago. I couldn't see it. No, but we could see your presentation. Oh, sorry. So I'm going to do it again. I'm sorry for this waste of time. This is not what usually happens. Perfect, we see it very well. Now we no longer see it. Now, yes, yes, now, yes, and we see you too. Well, I'm sorry for all these inconveniences. No, so after all the presentations and the introductions, what I'm going to say is the same study, but with two differences. A few months before the iShare study, we conducted a similar study in Mexico, not exactly the same, but I'm going to compare the data. And I adopted two decisions. iShare is very broad with many dimensions. And as was pointed out, they focus more on reproductive health. We have very little information that differ on reproductive health, I won't mention, but I'm going to focus more on the sexual part and the erotic part that the surveys show. And I'm going to share it. These two surveys are here. This is one in May, and this is the same iShare, but in October, and I won't repeat the details. I'll spare you the methodology details. So this is the team in Mexico that I participated in iShare in Mexico. I think that the dates are important. This is May, and this is from October to January 2021. That was the iShare study. And as is often pointed out, the participations were much more frequent among women, and there were some that were reported as non-binary or with some sexual preferences. In our country, it's the median was 39, and in the second 37 years in the median age but these are not representative surveys. They are out of convenience, but with an important sample of participants, 1,700 in the first survey and 1,600 in the second. And those were the differences as to sexual orientation. Most of them were heterosexual and an educational level. And this is important. It's from university up. This is typical of online surveys that are voluntary. And I think that it explains a lot of the results that we found. So the socioeconomic level was also high, medium to high, and in both surveys there was a significant percentage of participants that said that indeed they had been respected the healthy distance between participants, and this is important because the conclusions may be understood thinking of that. So I'm going to go fast. Tension, the stress, the tension in the couples, almost 40% of the participants reported that, while tension with the children too, 30%, 31% increase. And this is one of the important things. There was also an increase when 40% of the population reported an increase of emotional support. And as to sexual contact, the analysis is very simplified, what I'm going to show here. It's only the global data because we don't have much time. But in the May survey, 43% reported a global reduction of sexual expressions, and this reduction was even more remarkable among women. And in this iShare survey, this can be, you can identify the changes behavior by behavior, but the question that was more striking to us and that we wanted to share was the question that reveals the changes in satisfaction. There was a significant number of people that were very satisfied, and there was a reduction of satisfaction here, and there was an increase of the percentage of people that said that reported less satisfaction. So as to the erotic function, the problems appear here. In the May survey, we surveyed more in detail the sexual problems, and there were two comments that it's worth pointing out. There were two sexual problems. One is desire, and the other is arousal. So it is quite, there were more than half of the people before had these problems, and in iShare we see a very similar thing. There was an increase on the number of people that reported sexual problems, and this is in here. You see how these figures are reduced as compared to this, and an increase of the figures reporting sexual problems, and these were significant. The vulnerability of the sexual thing outside of home. And outside of home, there's an interesting thing. In the iShare survey, we found a clear reduction in the perception of vulnerability. So that makes sense of things that happen on the street in harassment and violence. This was reported as have reduced. Maybe the violence that we found that were very striking was the reaction in case of violence, and this is the iShare survey. Before the lockout, there was a 32% of people that had talked about violent cases, and no longer any claims, that were reduced remarkably down to 18%. The percentage went from 8 to 2% of the percentage of people that claimed having had violence, suffered violence. In the May survey, we used scales, the perceived violence. I won't discuss the details, but we found the same, more reported by males than by women in the iShare survey. I won't give you the analysis now, but the important thing here is the increase of post-lockout, about 10% of the people, plus the ones that already were suffering violence, almost 20% overall. We conducted an analysis that I'm going to present very quickly. It's a correlational by variable analysis to see the mental health and the violence indicators. We try to relate them with the changes in the sexual behavior, and we saw several correlations, not too intense, but certainly between the changes of the social behavior in the couples and the measurements of stress, anxiety, and violence by the sexual partner. I think that this is very interesting, because I think that what reveals, first of all, is that the change is not global, it's selective. Some people have an increase while others have a reduction. The violence probably in this segment, and this is the way I interpreted this, in this segment that we estimated with this surveys, probably don't reveal what we see in other cases, dramatic increases of sexual violence. So probably they are not so characteristic of this segment that we captured with these two surveys. And probably what's happening is that education, the relatively high educational level of the responders accounts for that difference. So it was not a representative sample. And the second conclusion that we consider relevant is that really the changes in sexual behavior are a sort of gauge of what's happening in the person's life and the quality of the couple's life. When the lockout had a great impact, you needed to look for other factors such as psychopathology or violence already installed in the couple. So the results here you can access the results in our website that I'm sharing with you. So I thank you a lot for your attention, and I hope we have a little time to comment it. Thank you, Eusebio. That was a wonderful presentation and absolutely clear. Thank you for being brief. And now the last talk, almost at the end, we are going to extend a few minutes more. So please forgive us, but we're going to listen to Nicolas, your colleague of Uruguay, who will present his data in a video. Please, could you put Nicolas's video, and we would have some time, some minutes for questions, and we now we're going to have the problems. So we're going to see the video. Well, thank you all. And first of all, I wanted to thank the organizers for inviting me. This was a very important webinar, especially the WAS and PAHO, and of course, CLAP in Montevideo. I'm Nicolas Brunet, and I'm a researcher of the Institute for Health Psychology at the university. Well, and I was already introduced by Rodolfo in 2020. I was one of the participants together with Dr. Lopez of the implementation of this international study on sexual and reproductive health in COVID-19. In Uruguay, it was Aisha. Rodolfo told me that by now in the webinar, you would already know about the general characteristics of the study, so I won't discuss that, but I'll just try to present the results and some final conclusions so that you can discuss it. So I'd like to mention a couple of methodologic aspects of Uruguay. You know that there are some differences in the countries. In Uruguay, we you can, as you know, the differences in the public, it's different. In Uruguay, we had the changes.
And we used these apps you can see here on screen, varying them according to the population we needed in each period. Males that are the more difficult to capture with these surveys. Our sample was close to 700 cases, and as you may see, some important jumps in new cases are related with the inclusion of apps more related to males. Here, briefly, to say this is an online sample. This has some constraints in Uruguay in particular. It was a relatively young urban situation, rather educated with an appropriate social and economic status, and must be borne in mind when looking at the results. In terms of income during COVID in Uruguay, we saw close to 40% of people responding to the survey reporting losing income in 30% of cases. In most, we're speaking of a partial loss, but in 5% stated total loss of income. The results will be always presented separate for males and females, as shown here in terms of changes in the economic status of homes. Here we see that nearly 40% declared the economic situation in the home had worsened. In regional terms, we observed a higher rate of worsening in the northern part of the country, in some locations that traditionally are more vulnerable. As for the tensions and support with a couple during COVID, we saw interesting results. For example, close to 30% declared increased tensions with the partner during COVID. This percentage of individuals that perceive this increase in tensions is quite high among those where the economic situation worsened as compared to those who remained the same, in this case, 40%. And in terms of emotional support of the partner during COVID, we identified that close to half, depends on sex, 50-60% didn't receive a change in the support received by the partner. And we see a higher proportion of women that perceive increased support as compared to the time before. As to the frequency of sexual activity, an important issue in this webinar, we saw differences in activity and physical contact and satisfaction, always according to our methodology before and after. In general terms, regarding frequency of sexual activity with a stable partner before and after COVID, we saw a general reduction of sexual activity with a stable partner, reflected in increased frequency of low monthly frequencies or never, and a increase of reduction of higher frequency, a relative decrease of sexual activity of casual sex during COVID, and both, if we consider it according to sex or gender, we didn't see differences in general terms, but we did observe an increase of levels of general insatisfaction, both in males and females. As for the use of condom, we're working a bit more with this, and we found an important increase of those who had never used condom with a stable partner, particularly with males, but not only, also in women. But we didn't see specific change in the frequency of those that always use a condom with the casual partners, but there's a clear increase of those who declare who have never used a condom in casual relationships. This at all ages and for all religious beliefs. In terms of services used to access contraceptives, it didn't change much in Uruguay. It's still the drugstore. And now to leave you with the optional mode for the study on mental health, where we observed an increase in self-perceived depression that is higher as compared to before. 40% of those surveyed responded they were undergoing the situation, and over half in the north of the country. And although this instrument has its limitations, it's relevant and must be borne in mind, because many international trials are showing a similar trend. To end, I wanted to say that the idea is to continue with longitudinal analysis of post-pandemic sexual and reproductive health surveys. And the idea is to continue working in this way. We used to have representative studies, but there are some methodological innovations that could allow us to respond to data and try to find higher representativity and certainty when identifying working hypotheses for intervention and guide public policies. Thank you for your attention. Greetings to both organizers and other participants, and I'm open for questions. Well, just a very short analysis of the questions received, because there are many, but focused on two areas. One, essentially, the impact of COVID on health in general terms, and this provided a general overview in PAHO that has allowed us to deepen further on sexual health, and it was important to discriminate it from reproductive health. And in that sense, there are many comments and questions regarding the impact, particularly at economic level. And maybe it is there that we can have a conclusion about the need to work in an intersectional way. Another thing that has been repeated and observed in many questions and comments regards the impact of gender standards, meaning that apparently this is reflected in studies whereby women accept and believe and normalize violence and don't report it because they cannot identify it. And in that sense, we also have many questions made and fortunately answered also by the interaction in the chat. I think that all the studies we've heard about provide this condition of allowing us to see the local specificity, but at the same time, the global conditions leading us towards a future where we will have to deepen further in our analysis to specifically look at these impacts at local level and how this evidence can inform public policies and also strategic measures taken regarding this that we will call the post-COVID era, that will require a totally different approach of health and sexual health in particular. And also, how can we work in order to implement regional measures and strategies and global measures and strategies in that sense? Rodolfo, then, the two major conclusions that cross everything we've heard today and that have been extremely detailed. So the floor is yours before handing the floor to our colleague from WAS for the closure. Rodolfo, are you there? Yes, please. Having said this, we are practically ending our seminar. So on behalf of PAHO, Rodolfo? Yes, thank you, Esther. Let's thank on behalf of Pan-American Health Association. I wish to convey warm greetings from our director, Dr. Suzanne Seruja, CLAP director, who hasn't been able to be with us today, but very warmly has sent her warm greetings. And there's this joint work we want to highlight and protect. This joint work is an honor for PAHO, having WAS as a partner, a non-governmental partner that every year validates its activities together with PAHO. We have a joint work plan that is validated and approved by our executive board, and we've received approval of today's activities and those presented next year. So on behalf of Luis, Esther, and Pedro, we want to establish and strengthen this working relationship, understanding that the universal access to health cannot leave aside sexual health. That is related, but is clearly discriminated from reproductive health. So thank you. It's with joy that we have greetings. And now we would like to hear you, Luis, to close this wonderful seminar. Thank you. I'm sorry, I can't hear him. Good afternoon. I don't know if you can see me and hear me. Yes. Good. Thank you. Because, well, I would like to thank for the joint work and a brief comment. Since the year 2000, historically, sexual health definition has been elaborated together with PAHO in the old Guatemala. You can see this document defining sexual health recommendations for action. So that's when we started working closely with PAHO, and thanks to these seminars and issues such as I share, we can make visible what people couldn't speak about, such as non-binary issues of sexual orientations, and ask more things about in relation to the digital space, and we can speak and empower in relation to areas that didn't have room before due to political and cultural areas, things that are hard to speak about and express, and more clearly understand issues such as violence that we have really seen today. And this possibility of speaking seriously about sexuality and sexual health. And these spaces allow us to consider what has been done in WAS, the Declaration of Sexual Rights in 2014, in line with the Declaration of Sexual Rights, the Declaration of Sexual Pleasure. This has already 2 years since the Mexico conference without leaving anybody behind. That's an issue that we must consider also for mental health. This is an unequal world. We want everybody as insofar as possible today and to reach a fairer world. That is our challenge, and we invite you to work towards it in the future in WAS, Sexual Health for All. Thank you for allowing me to participate in this seminar. Okay, an announcement. This recording will be available in the 2 languages, both in English and Spanish, and we'll have a document to share with the over 200 participants we had today and over 1,000 people who registered interested in the seminar. So we'll share this final reference document. Thank you. This is the end, and we apologize for taking 15 minutes more than we planned. Thank you. See you soon. If the panelists want to turn on their videos, we can say goodbye of our very kind audience. Thank you.